Welcome back to Bitesized Learning. Today we'll be talking with Sarah about delirium. Sarah, could you introduce yourself?
Hi, I'm Sarah. I'm the lead nurse for the Cognition and Mental Health in Ageing service line.
So Sarah, what is delirium?
Delirium refers to an acute stage of confusion where the onset is quite sudden and rapid. Delirium is often mistaken for dementia because the symptoms can be quite similar. One of the important factors when kind of assessing for delirium is understanding the onset.
What are the typical signs and symptoms?
So the onset is usually over days rather than months, as you might see in dementia. Patients may present with a clouding of consciousness, difficulty maintaining or shifting attention. They may present as disorientated and experience illusions or hallucinations. And you might also see fluctuating levels of consciousness. Now, with delirium, symptoms tend to fluctuate over the course of the day, with some improvement in the daytime and maximum disturbance at night. Reversal of the sleep-wake cycle is also common.
So, what are the main causes of delirium?
There are many causes of delirium. The main cause is an infection really anywhere in the body. Urine infections are more commonly found in older patients with delirium. Other causes of delirium include temporary blockage of blood to the brain, known as a TIA, drug misuse, alcohol poisoning or alcohol withdrawal, lack of oxygen in the blood. Certain medications can also cause delirium, so things like digoxin, diuretics, steroids and opiates.
And finally, what would be the ward-based management techniques?
So physical observations are really important in managing people who have delirium. So that's blood pressure, pulse, saturation levels, respiration rate, and also their blood sugar. If you suspect someone has delirium or their physical observations aren't what they usually are, let your ward doctor or the duty doctor know. It's really important to assess and evaluate what could be the cause of delirium because that needs to be treated before the delirium resolves. Sometimes patients can present as quite distressed or agitated. Where this might be the case, the first thing to do would be use verbal de-escalation techniques. If this persists, you can consider pharmacological interventions. Ward staff must also look at kind of the level of observation. If their presentation is quite fluctuant, you might want to consider whether they need an increased level of observation just until their behaviour settles and the delirium, the main symptoms resolve.
Thank you so much for speaking with us today. I've definitely got a better understanding of delirium.